and we'll move on and get to some introductions. Siri wants to come to the meeting. She's confused, so. Okay, great. Why don't we start with people on the phone today?
Hi, this is Barbara Epstein. I'm on the phone, but I'm on the way.
Oh, great, Barbara. Thank you. Greg, do you have others on the webinar?
You need to turn on your microphone.
Here, grab a microphone.
Good morning. We have John Hamper, and we have Tony Tucker.
Hi, this is Tony.
Hi, Tony. Welcome. Is there anyone else?
Thanks.
Any other non-members on the?
Oh yes, we have Bailey Orshan. We have Brian Wall, Ted Perman,
Joining us. Ted's on the work group, and Bailey is from Mathematica, and they'll be doing a presentation on some of their analytic report work that they've been doing for us. And now we can.
Either or both Brian and Chad are on microphones, which was that feedback that was just coming, so they need to call in, be able to unmute them if they need to speak.
Okay, great. Thank you. So they can.
You'll have to tell them. Oh, I don't know.
Oh, you were speaking into the microphone, so I think they heard. Okay, I think we can start around the room then. I'm Diane Feeney on the quality team at HSCRC.
Brigadovich, HSCRC.
Allison Schuster, HSCRC.
Bob Murray, I'm representing Care First.
Thelma Baker, VHQC.
Dan Cochran, Shady Grove Medical Center.
I'm Zahid Butt, Medisol.
Ed Baranek, Johns Hopkins.
Pat Ercolano, University of Maryland.
Justin Dybel, Mercer Medical Center.
Tracy Laval from the Maryland Hospital Association.
Trisha Roddy, DHMH Medicaid.
Denise Johnson, HSCRC.
Andy Udom, HSCRC.
Great, and we have several folks in the audience to welcome. Thank you for coming. We're going to start off with our MHAC program. First, we'll talk about some considerations for updating the program for fiscal 18. And we'll go through the first couple of slides. Then I'll ask our Mathematica colleagues, I think it's Bailey, Orshan, and Beijing, will discuss the preliminary findings from their validity and reliability testing of MHACs. And then we'll move on and talk about readmission reduction considerations and other related adjustments. And then we'll end up talking probably briefly about the aggregate at risk for quality programs. How much money are we putting at the table or proposing for fiscal 18? So if we can flip the slide. Oh, thank you, Greg. For the Maryland Hospital Acquired Conditions Program, I think we have discussed the fact that I-10 will actually have an impact as we think about how we're going to measure 17, as well as how we potentially may measure for fiscal 18. So for fiscal 17, we will have 12 months in I-9 in the base period, and then 9 months of performance data will be in I-9, and then 3 months potentially will be in I-10. So one issue will be that Mathematica is going to help us look at, as we have these nine months and 3 months, what is the stability or accuracy of the data as it gets coded in I-10, and do we see any large changes that we need to be concerned about? So we can sort of get an early read on that probably in February, March, and then we can bring that to the work group, and then we would need to discuss some alternatives. Would we want to just use 9 months of I-9 and sort of annualize that and compared to the base in I-9, or would we want to shift the performance period back by 3 months and overlap by 3 months? Well, actually, it's not an overlap because there's a 6-month gap. Sorry. So we could shift back. That's an alternative. Shift back by 3 months for the measurement period, similar to how we're doing some of the QBR measures. So I want to just stop there for a minute, and we can talk about it. Unless it is what it is, and we need the information before we can I don't know if anyone would have any ideas.
I think those are all reasonable options to keep on the table, and hopefully there won't be a lot of shifts, but we'll just have to see.
Mm-hmm. And then just as we think about I-10 as it relates to fiscal 18, we'll have 12 months in I-9 in the base and 12 months of I-10 in the performance period. So if there is an impact of I-10, it may be more or less dramatic depending on how coding settles out. Like I'm really hoping I-10 becomes Y2K for us, which was a non-event, you know. But and especially since the approach that's being taken is it's the assignment of the Ppc'S are as if it was coded in I-9 in terms of how the mapping works. So so hopefully that won't become a huge issue going forward. Okay, I want to talk just as a third bullet on this slide. I'm going to ask Mathematica to chime in a moment. So I'll skip to the third bullet. There are several issues that we want to put on the table for consideration for the Ppc'S when we think about fiscal 18. Based on reliability and validity testing, we're going to get some additional input from 3M that may be additive and helpful at this juncture about, you know, in terms of advice about approach to either merging some of the Ppc'S, suspending potentially a small number of the Ppc'S, and then we do have some Ppc listings for some tiers, but mainly we're focused in that table when after Mathematica presents. It'll show what tier 1 Ppc'S the most, the ones that may be weighted the most heavily, and those that have been brought to us through MHA by the industry that you believe are the ones that we should focus on as we go forward, because there's been a little bit of a shift in thinking about those particular, which Ppc'S fit into that set. So we took those Ppc'S and put them in a table and sort of, we have a preliminary read or potential options for where they may shift with this new information on reliability and validity. Also, if there are some that are clinically alike, but one has a low reliability and another does not. There may be some value in combining a couple of those clinically similar, or at least focused on a similar patient population, potentially, like the GI complications or something that comes, or the obstetric ones. So that issue does come into play for a couple of those, for a handful of those particular PPCs. And then we will also need to consider weighting. So if we, for instance, were to go from a 3-tier to a 2-tier PPC approach, how much would we want to think about weighting Tier 1 versus Tier 2 to reflect the import and ability to improve that people believe is there for the particular PPCs in those groupings. So, and we are thinking right now is that a two-tier PPC approach may be a good shift from the 3 tiers that we have currently in the program. And for revenue at risk, we are not thinking there should be any changes for fiscal 18, but we do have a slide that lists the revenue at risk for each of the programs, and we could have a discussion now about that, or wait till we get to aggregate at risk. Because I think people have wanted to see all the programs lined up next to each other so that we can have a more comprehensive and holistic view of that issue. So looks like we want to wait for a minute on that one. Okay, and then we also lastly need to determine a statewide target for improving by which we can go to a lower at-risk amount, which is the 1%, versus 3%, which is what we have now for not meeting the statewide target. And at this point, based on the data, we do believe that we should set a target that is not 0, but is not potentially as rigorous as we've had in the past. This slide here shows that it lists both the number of complications from fiscal 13 to fiscal 15, and also the cumulative improvement from between 13 and 15. So I remember in the beginning we had 53,000 complications for PPCs. So what we have now are 17,000. So we have 1/3 of the complications that we had in the beginning. From I guess that was around 2009 when we had that 53,000. And that, of course, represents a substantial percentage decrease year upon year and cumulatively, as the slide indicates. Another analysis that Allison actually did was to look at if every hospital was at least at the statewide average or below, because some are above. What kind of improvement would that mean? And that would mean that we would need an 18% improvement again for fiscal 18. So I think taking all of that into consideration, staff is thinking around 6% seems to be a very reasonable target, and would be achievable, and would also provide a bar that was meaningful for programs. So we can discuss that if people are sort of inclined to do that right now.
So we haven't talked about a specific target yet at all, but what we have talked about is kind of just pulling this back a little bit. Before we talked about how much should be at risk and some of these details, which we do need to get to. But what we've said is, I think we're in agreement with this, is we've had so much improvement over these years. We've hit the waiver target. The program should not be as aggressive as it has been. And there are several different levers within this policy to be able to make it less aggressive. One is setting the statewide target. The others that are they're harder to see, but it's with the norms that are used and the how the benchmarks are set. So when we change those norms and change the benchmarks, those also inherently make the program more aggressive and difficult to hit the same target. So that's another place that we should consider keeping stable for this year. As if we held the norms the same and continued to use those same norms, then we could know more easily how much improvement should we expect and in which Ppc'S to expect that for the coming year. So it's another way to do this.
And I think we had similar conversations last year. And I think our plan was to do the things that we've always done of updating the benchmarks and thresholds. But you're correct, there are multiple levers, and they need to consider them across.
This is Pat. I'd like to ask consideration. I think the concern that the hospitals have at this point is we really are starting to see a significant separation of hospitals based on performance. That's indicating not all hospitals can meet the same performance. And again, that goes back into our conversation about clinical services. And while I'm not going to challenge the fact that we can't improve anymore, what I do need to challenge is that we need to think about the program differently. We now need to think about the patient populations and the clinical services. And to just assume we can continue to do the same thing, I think we're putting hospitals at risk. We did kind of do just a scenario of the rebasing, and the number of hospitals at risk and the performance of those hospitals is not aligned with when we think about the performance that they actually have achieved.
And I'll just add on to what Pat was saying. I think this is a good point, and to say it in a slightly different way is that as we have reduced more and more complications, particularly on some complications, it may not be for all of them, but particularly on some complications, you do tend to see certain types of hospitals as the best performers in certain complications. So I don't know why that is, but it does raise flags that if you see clusters of hospitals of one type or another, hospitals with certain characteristics who are always the best performers or always the worst performers, it does raise questions about, is there some bias within the measurement of those Ppc'S? And I think that's where Pat's comments are coming from. That's where our concern with continuing to follow the same approach that we have in the successive years. So not saying that we shouldn't have improvement, not saying that we shouldn't continue to do better, but we have to, I think, tread carefully here. And
I think those are valid comments, but I think people in the group would benefit from more specific examples of what you're talking about, and to try to connect the dots rather than just make those general comments and say, as a result of that, we shouldn't push quite so hard.
Then I'd like to ask our opportunity to bring those, because we can look at them by clinical service.
So here's the question to me in terms of timing. If you are really thinking about revising the whole, we are in the process of extending our waiver, trying to get the physician waivers from the CMMI, and also we will be starting the process for phase 2. And within all those, the intention is to bring the non-hospital measurement and impacts to our programs. So, and as you know, in our strategic plan, the intention is to look at all our programs and then revise them according to the needs of the phase 2, or even to make our hospital waivers successful. So my question to you is, sure, we could always go back and do different modeling and try to address some of your concerns, but is it the right time now to do this in November, when we have, if you keep the schedule and keep the promise in your request that we give everything ahead of time to you, that means December. So, I mean, Yes, I think in the clinical look at it, so basically the idea is rather than creating a hospital PPC rate, could we score them based on different clinical domains, right? That's what the intention is. So then you would have a score for surgery, you would have a separate score for medical clinics, or maybe in more detail, and I think that's what we want to go eventually. But in terms of the timing and the energy that we would need to spend on revising a program that seems to be working, is that a good use of our, is that a priority given what other things we need to do?
And plus there are the other massive changes that are coming down. The architecture isn't up for that. So what if we revise it and then we've got to do it again? Which is that rapid change for a program in terms of its stability is not helpful.
Yeah. So if I could just break in here. So what Pat is referring to is the analysis that's been done that looks at the service line, and it does raise some of these questions. So the hospital field has talked about this, has looked at the methodology, likes it, thinks that there is merit there, but agrees with you on the timing, is that the timing isn't right to do this for calendar 16 for all those reasons that you mentioned. So we're not saying make that wholesale change in this year, but I think there are pieces that can be pulled out of that that mean that we don't need to necessarily change the structure of the program in this coming year, but we can take lessons from that. And to the good point that Bob made, it's on us to pull out a couple of examples and bring them so that maybe on these, particularly on some complications, some groups of complications, we can address those. And I would suggest maybe the way to address those specific complications would be to reconsider what the benchmarks are, or reconsider what norms are used for those specific PPCs that do seem to have particular issues. I think it appears that there may be, we don't know the magnitude of that issue yet. We don't know the magnitude of that issue, but we know that there are some differences. So I think it's on us to bring some examples and show those examples and see if there's a way to make modifications to the current structure of the program to try to bring some fairness and address some of the issues that have been raised that we're seeing. But again, to take heed of your good points about the timing, that this is November 20th and new performance period starts in January, and we don't want to be really changing the methodology into March and then not having data on how we're doing in April. So
yeah, and I think besides timing issue is kind of thinking about what does it mean to have a hospital performance payment system in the new world, in the global budgets, right? So if you are moving towards more clinically based, patient-centric, do we still keep those measures in separate programs, have a PPC program, have a readmission program, have a QBR program, or do we look at holistically and say, for a hospital to get defined value, that they have to have all of them, right? So that kind of a discussion we need to have if you are really going to be changing the program. So, you know, if a hospital has both low PPC rate, low readmission rate, and low mortality, does that have an added value to it, right? Because they're achieving all those important aims all together. They are, you know, versus adding them all up, you know, as simple math. So I think we need to discuss that and think about these as we are moving forward. And with that, I think we could kind of keep in mind all the things we learned from our existing programs and see if we could address some of the issues.
I think, again, the hospital position is 100% supportive of what you're saying. But what we are asking is that we do recognize that the current program has its limitations, and the lower we get, the more those limitations are becoming apparent. And two, we do need time to develop. So let's not penalize in between using the same program that we know is now putting hospitals at risk for a performance that may not be appropriate, as we're waiting to drive. I was listening in the car on the way. Sorry. I want to comment
For
on
people on the phone, I'm sorry, can we try to introduce ourselves?
Oh, yes, I'm sorry. I'm Barbara Epke from LifeBridge Health. First of all, I do think what you're talking about, Shule, is the ultimate quality score. I think it's very complicated. I think it takes a long time to study. You know, as a statistician, it takes a long time to figure out how those alignments work if you're to come up with one composite score. And I think that's way out there. So I agree with, Tracy, that requires a lot of study. While I was listening on the way in and there was a request about specifics, I do think, my thought has been, I've given this a lot of thought, we've come a long way. And I think we've talked a great deal about everything from coding to documentation to the true quality. Where is the true quality? Aspiration pneumonia, maybe OB, it depends on the hospital. I do think there are two questions I have. One is I need to better understand if we were to collapse and change the tiers in any way, because I don't know the study that's gone into that. But the second thing is there are some examples, and I'll give you one. And I know we don't want to get sidetracked today, but if there are experts offline that we'd like to get together, it might be a good idea. OB. And I'll use my own hospital, Sinai, as an example. Our OB program has been touted for being great for high-risk moms. We've had great results. We've had a lot of accolades for OB. OB is one of our crown jewels. We look awful. And why? Laceration. Definition clinically, now maybe we take things too much to the nth degree. Maybe we punish ourselves more than other hospitals do. I don't know. We're trying to follow the rules exactly. But if you take a look at that, there are some discrepancies between what the real quality, in quotes, has been defined as versus the Ppc'S. And it might be time, for instance, to collapse some of those Ppc'S so that you don't have so many, or to redefine one or two. So I think, Bob, was that you on the phone, that I heard saying give us some specifics?
Yes, it wasn't clear what specific means.
That's one. I mean, I think there are others, and in my mind, when you've had this measure of success, and I think what I can say, because I've been on the Hospital Association Quality Committee for years and led it for 4 years, I think I can truly say that we've wakened up in Maryland. Remember years ago, Diane, when we were like in the low range of the states? I think we've all gotten it, the public reporting, and these programs have made a huge difference for us. We take it very seriously. We already look at specialty specific at our hospitals. I know Pat do and others do, because that's how you study. Is it quality? Is it documentation? Is it doc? Are there doc clusters? So all I'm saying is two things. One, we probably now can step back and do a little bit of evaluation, and you're doing it, but we have to do it together. And the second piece is I may have missed a beat. I've been in and out of work lately because I've had some surgery, but I need to understand the collapsing of the tiers and what that even means. Because when I look at OB, I understand why OB was tier C. There are a lot of separate indicators. We ought to evaluate that. But I'm just using that as an example. Pat or Ed may have different examples. So, yep.
So maybe about
just confused as to what, on one hand, it sounds like there may be a longer-term effort to try to revise things more substantially, but on the other hand, time is short, so we don't want to revise things too much. Is that what we're saying, or so staff would be receptive to longer-term discussion about how to? But in the meantime, we've got a time frame and we've got responsibilities relative to the feds and the waiver, and we don't want to disrupt things too much because the performance period is starting very quickly. Is that sort of what we're getting to by this discussion, or?
Yeah, I think the common things we want to look at is the Ppc'S, which was also in the plan to look at the Ppc specific rates and look at their reliability. So I think Mathematica is going to talk about that in a minute. But from that analysis, we thought maybe there are Ppc'S that we could suspend, that we think that they are really not reliable. And then there are places where when we looked at it, we kind of said, oh, it might be the issue on the OB case, the laceration first and second. It could be the degree, the issues around defining a nuance between the third and the fourth, or the blood measurement. So maybe then we say, well, maybe it may make sense to combine them rather than completely suspend, because OB, we included them only 2 years ago, and we don't want to turn the tide again and take the focus away from it. At the end of the day, as you know, if you don't use it, then the data will never get better. So I think our approach is to kind of work on PPC list and then see if we could get a better sense of what we want to do with the PPC list, but not change the general methodology.
And I think part of our part of mathematics and our discussion of moving to 2 tiers is tier 2 had very few. And as we're looking at some of the ones to suspend, some of those are there. So it's just becoming much narrower. But what we weight those 2 tiers at, it is open for discussion and open for modeling. And so, again, going back to what the levers are in terms of what's in that second tier, what after Mathematica presents, what we focused on for here at least was, okay, what's going to be in tier 1? We'll leave the rest because those are going to be things that we may be dropping, things we may be combining, but we'll have that, we'll have to have that conversation afterwards. But if we could focus today on these are the ones we think should be in tier 1 and the other things later.
I think collapsing and combining several of these would make a lot of clinical sense also, make it more relevant to providers as they try to understand these. And there are obviously many examples that one can give within the list, and I think it would be something that would clearly be done based on input from various folks. The other question that I had is that certainly there's an absolute reduction in the rate, in the absolute numbers. Is there another denominator that plays into this, as in number of discharges or number of inpatient days per inpatient days?
So on here is the case mix adjusted complication rate, which would take into account the number of discharges and changes in the number of discharges over time.
So the rate itself shows this amount of reduction over time?
So when you look at the number, the cumulative one, just in the pure number, is 39.1%.
Right. So that's
when you do the rate, it's 36%. So that's taking into account both the changes in admission, but also the changes in the case mix of the patient.
Right. Okay. Thank you.
Can I ask, so what is your consideration? So I think the tier piece makes sense. As you, Allison, identify, the fact is when one tier is just getting so small, obviously it does make sense. I'm still not hearing a response, though, in relation to, again, the expectation we're holding for hospitals with much higher complicated patients. I'm still hearing the same expectation of benchmark.
And we had that discussion last year, if you remember, in terms of changing the time period for the benchmarks. And I'm really, we need to look at it, but I want to fix the PPC list first and then go back and do the modeling. I think that it's not clear to me that what you're observing is the issues around the PPC. If you really do get a select PPC list, do you see the same issues or not, or is it just about those PPCs impacting certain hospitals? So we want to look at that a little bit. But in terms of the expected rates, in my mind, we already fixed the scaling, right? The scaling is fixed. The points are fixed. So if you also use an old time period for expected rates, if I were CMS, I would look at our results and say, what are you doing here? Is it, at the end of the day, I think we are going to be measuring you over 2 years of period if you just keep the expected rates the same, right? Is that what you want to do?
No, I'm going back to the benchmark issue. It's the expected rates are based on performance, so I understand that. It's the benchmark that a Hopkins and a University of Maryland is being held to, when that benchmark is being set by hospitals that don't have the same patient population. So therefore, our ability to continue this improvement to reach those targets is just becoming more and more and more obvious of the difficulty of that. Yeah.
Wouldn't the risk adjustment take that into account?
It's not.
No?
So maybe it would help to see some of the work that Mathematica has done on the Ppc'S, and that may inform some of this discussion.
Thank you, Tracy.
And I think I have to push back a little bit on that, because the standard response that you hear from clinicians, and not just hospitals but physicians, is no, I have problems because my patients are sicker. And so are we talking about patients from deprived areas and not having adjustments?
We're talking about if you go into Hopkins or University of Maryland and you have a transplant procedure done, the complications that you receive are different in the sense of how preventable they are compared to if I go in for a cholecystectomy. But yet they're being held to the same standard.
But the patients that are in those categories, though, that's
your expected, it does make a difference, but your benchmark is driven by the hospital that's doing the cholecystectomy.
Tracy, it might help if we brought an example back, but it's a fine distinction. So if I can get an example right in my head, if we had just one complication, what could we make it be? Pneumonia. If we had pneumonia, and one hospital's caseload was all patients who had, I don't know, some major surgery, and another hospitals were all psychiatric. So even though there's a different expected value that generates there's a different norm for that APR, so it generates a different expected value. Just the sheer numbers of that complication is not coming out very good. I need to put an example.
Yeah, I think once maybe if we focus on the PPC list on this meeting and then get your feedback, and maybe between this and the next meeting we get that done, and then for the next meeting we appreciate if you bring the examples, and then we can talk about the way we set the benchmarks. But I would let's talk about the benchmarks rather than the expected rates, which makes it much easier to work with.
But see, I come back again to if people are questioning that the risk adjustment is not working, then there's nothing that would account for what you're saying.
It is
because the risk adjustment is the methodology by which normalization occurs. And so if people feel that that methodology is not doing it, then there's nothing else you can do.
Well,
I think it's,
come back
we'll come.
It sounds like it's something different.
It is.
Right.
Yeah,
So
it's not the risk adjustment itself. It's more that if you say, so I think, let me try just one more minute on this example. I think I might get it. But so following on the same way that we were, if you say for the risk adjustment for that, the norms, that's okay. But when you look at the best practice, the hospital with all of the psychiatric patients will have a much lower best performance than the hospital with all of the surgeries. So that's where it gets to that it's the benchmark. It's still not coming through.
The hospital with the psychiatric patient will have a much lower severity of expected rate. So it's all accounted for within that.
We'll come back.
Yeah,
I appreciate the opportunity to just have that,
right,
that ability to bring it back.
Actually, as they are trying to address this, can they also look at the predominant levels? If those cells are predominantly dominated by Hopkins and University, then what you're at say?
No, we're not.
May I mention just one more point? I know we want to move on, but one more thing. Let me use OB again as an example. First of all, there are deliveries and those that are extremely complicated. And your severity adjusting, I think what we're saying is severity adjusting is very complex, and we can't know without stepping back and really looking at it deeper how thorough it really is for all of the Ppc'S. It may be very thorough for certain diagnoses, but it may not be for others. and there are so many factors. Say, again, a delivery, because everybody understands OB, but severity adjusting doesn't always work as finely tuned. It's not that it doesn't work at all, it's that we have to step back and take a look at it again, because it's working in some areas and it isn't in others, because we have the proof of the outcomes in the quality at various organizations that we have to back that up. That's all I think we're saying. Right, Tracy?
I mean, we did do, so one of the ways to look at it is compare the PPC rates to the outcomes, right? So if it is not adjusting appropriately, then you, like Barbara, you said, you may have a high PPC rate, but you have an excellent HCAP scores or lower readmission rates. So we did look at them, but they are correlated with mortality. A bunch of them that you expect. They are correlated with length of stay. So you kind of see there that the measurement is valid, and I think maybe it's it might be good to get Mathematica analysis so that they could kind of talk about it a little bit.
All right. I think we're having a
I
technical
think we may have an issue.
That's why we're not moving as quickly to Mathematica.
Well, if we got 2 seconds, I'll take
it. Yeah, go ahead.
So I want to get back to your point. So if we're looking at hospitals that do thoracic surgery, and we just take that patient population, and I'm going to use pneumonia just because it's probably not the best, but so we look at the patient population that had thoracic surgery, and we look at that observed to expected. That observed to expected in that patient population is significantly higher than the observed to expected in your congestive heart failure patient. And that's the issue of where the benchmark is being driven down here. But if you took all hospitals, so not one hospital, not one provider, but all hospitals that are doing thoracic surgery, that OE that would set that benchmark is going to be very different than when you take all pneumonia, which is what we're doing now. That's the part that really drives our concern, because we can't get, when you look at all practices doing that patient care, they're not getting to that benchmark.
Please bring math to us so we'll understand better. Because in our minds, for surgery, you have a high expected rate already. So then, yes, observed are high. I'm not following it. Sorry. Yeah. So yeah, I mean, we do see some. Yeah, we just need to. We are open to look at it and see if we could make adjustments to the existing one. But theoretically, APR-DRGs are taking care of it.
Yeah, I think that would be the only big issue that you raised. That is the underlying SOI representative of enough of sampling,
right.
And that's the only issue. So my comments are not that the risk adjustment is beyond questioning. I'm simply saying that as a framework, unless you accept it, then because everybody's patients are going to be different, and you've got to have some normalization process that everyone has some confidence in. And yes, maybe there are some that may need to be looked at with some additional depth, but I sort of heard several people say that they don't trust the risk adjustment in some fashion. So that was my initial reaction, that if that's how everybody feels, then it's going to be hard to compare people.
Certainly that's not what we feel.
Yeah, so I think there's definitely some room for more discussion.
Yeah, and neither CMS. I mean,
yeah. Right.
So what's going on with our...
Maybe you could suggest that people follow along with the hard copy vote.
You want me to do it? Oh, it's just a... Bailey or Faye, can they talk and can we hear them?
Yep.
So this is Bailey. Oh, perfect. You can hear both of us.
All right. So we are just putting up your presentation, but we have hard copies too, as Bob said, so we could All right, it's up now. All right, the baton is on you. And we'll move the slide.
Sure.
Dave, would you like to be the presenter?
Yes.
Okay. So did you give it to him? Did you give him the baton? Thank you.
So for this one, let me see.
So this is the next phase of our webinar, trying to get somebody else to drive it. I think we'll just drive it and then we'll figure it out later. Is that okay?
Yeah, I'll do it. Just tell me when to change slides, okay?
Sounds good. Yeah. But I think I cannot see
the slide.
Yep.
Oh. So we're on slide number 2.
That's the first slide after the cover page.
Sounds good. Okay. Yeah. For some reason, I cannot see the slides from my screen. But okay, I will run the slides from my local machine simultaneously. Okay. Yep.
Just tell me when to move.
Sounds great. Okay. Yep. So thanks for having us to present our preliminary findings on the reliability and validity of the Ppc's. And as you can see, this is a joint work with my colleagues from Mathematica. And by the way, I'm facing a data scientist at Mathematica. If we look at the second slide, here, first of all, I would like to give a quick overview of the Ppc measure testing. So in this, the Ppc reliability and validity testing, we really touches several components of this testing. The first one is about the reliability. So reliability is essentially about the precision of a quality measure. And in this testing, we adopt a signal-to-noise framework to estimate the reliability of each Ppc measure. And specifically, the reliability is represented as a ratio of the signal variation to the total variation. Total variation is the sum of the signal and the noise. Here, when we talk about the signal, that is the captures about the between provider variations. And when we talk about the noise, it's mainly focusing on the within provider sampling variation or sampling errors, something like that. And for the validity testing part, we mainly focus on 2 components. The first one is we would like to evaluate the predictive validity by conducting correlation analysis of hospital Ppc's over a different time period. And for the second component,
oh my goodness,
Faye, you cut off. I'm sorry, so we can't hear you right now, but in a minute, hopefully you'll be back online.
I was given the thing back to
What's his name?
Faye.
He said he's going to call back in. He's not sure what happened.
Okay, thanks, Bailey.
Yeah, it could be on our side.
I did it. He's calling back in. There it is.
Well, that's what I was doing until you.
Right.
That or is
That's
that?
what
we were doing. We had a.
We can skip this and come back. Do you guys want to do that so that we don't? So why don't we pause for the MHAC and then let's move to the readmission topic, and then we'll come back to it. And I apologize for the mishap.
Great. So this is Allison Schuster, for those on the phone, and we'll be going back to these the HSCRC slides on slide 7.
Hello?
Oh. Problem is they're not going to be over there.
Here. Hello?
Hey, we can hear you now. Okay.
Okay. So I apologize for the technical issue. So where did you lose me in the presentation?
The beginning, you were explaining the reliability to us.
Okay. Yeah.
Slide 2.
Slide 2. Sure. Okay. Yep. So can
Validity.
We go back?
You were on validity.
Yep. Sounds good. Okay. Let me quickly go over about our validity testing. The validity testing, we focus on 2 components. The first part is we evaluate the predictive validity by conducting a correlation analysis of hospital PPCs over time. And for the second component is we compare PPC results with external measures and criteria that are commensurate with the construct that current PPCs are capturing. And the overall testing idea is that we would like to do, we do a comprehensive evaluation of the PPCs, and our final proposals on the PPCs are based on overall results of the testings on each of the PPCs. Let's go to next slide, please. Okay, yep. So before, in the next few slides, we would like to talk about reliability. Before we walk through the reliability testing results, I would like to quickly illustrate the reliability framework we used in this study. So essentially, measure reliability is about the precision of a quality measure. So a measure with high reliability indicates that such quality measures actually ranks hospital by its quality of care rather than the random fluctuations or sampling errors. So we have graphics to illustrate the idea as shown in this slide. We could visualize the 2 scenarios of reliability conceptually, one with a high reliability and one with low reliability. So from this plot, if we see, for instance, the upper plot, the gray curve actually represents the distribution of the true performance of certain PPC for all hospitals. And the small red and blue bell-shaped curve you see illustrates the PPC measurement for a specific hospital. The measure result is, for such hospital, is spread around the hypothetical true performance, which is 0.7 in this illustration. And the variation can be due to within hospital sampling variation. So as we could see, if the overall within hospital sampling variations are small relative to the between hospital variation, such measure has a high reliability. Otherwise, the reliability is low. Before we move to the next slide, I just want to give a quick note on, make a quick note here. So reliability also relates to some other concepts that with policy importance. So for instance, like a misclassification. As shown in this slide, let's suppose, for instance, 0.6 is a benchmark value for this PPC. So hospitals with a low reliability for a measure in general has a high probability of a misclassification, as shown in the red area in this demo. So next slide, please.
Hey, can I ask a question here?
Sounds good. Yep.
This is Tracy from the Maryland Hospital Association. So I understand what you've presented so far. My question is about when we think about reliability, is one way to think about it to say the reliability of a measure is it's testing what we expect it to test? Like just to say what the concept is in words? Is that what we're trying to show with reliability?
I think I would put in this way. I think reliability is more about the precision of this measure. If when we talk about whether this measure is measuring what we intend or what we plan to measure, that is more for in the validity domain.
Okay, so reliability is more the concept of if I measure something, is what I'm measuring. Do I have a good yardstick for that measure?
Yep. And if you do conduct the results independently under the same situation for several times, you would like your results it's close to from one to another. So
okay.
Basically,
so another way of looking at it in this bar, in this graph, if it is unreliable, the chances of randomly picking the red zone is much higher than the one on the top. So this is kind of thinking about what is the noise, right? So if it is a noisy measure, your chances of picking the wrong, so there is the true value and then there is the wrong values, right? So the chances of picking the wrong values is much higher if the measure is not reliable.
Exactly, yeah.
Thank you.
Okay, so then in this slide, we would like to talk about specifically about our reliability testing. So in this study, we use fiscal year 2014 data as norms for the risk adjustment. And also, we conducted the reliability testing for all the PPC measures, and we choose 0.4 as a reliability cutoff point to distinguish a low reliability measure and a high reliability measure. So so one way to interpret the 0.4 is that, so that means if a PPC measure is reliable based on our standard here, that means that you at least need to have 40% of your total variation of the PPC results being explained by the between hospital variation or the signal. And one note we would like to put here is in the current MHAC program, there are 5 serious reportable PPCs. And for such PPCs, they are excluded from the reliability assessment, mainly due to their clinical importance in the program. Next slide, please. So in the next slide, we would like to go over about our findings, and we summarize in this table. So based on the standard we choose, we identify there are 12 PPCs with low reliability currently. And PPC 30, as you can see from the table, PPC 38 is from Tier A, and the 2 Tier B measures, which is the PPC 17 and 18, and the other rest low reliability PPCs are coming from Tier C. And another thing we can notice from this table is that for such low reliability PPCs, most of the hospital level reliability are also low. So for instance, if we look at the last 2 columns, for some of the PPCs, for instance, such as PPC 38, PPC 18, PPC 15, and some more, actually all the hospital level reliabilities, all hospitals, if we calculate the hospital level reliabilities, they are low, meaning below the 0.4 threshold. Next slide, please. Okay, so in the next part, we would like to talk about our validity testing. And as we mentioned before, we consider 2 components here, and one is about the predictive validity, meaning that the current results actually predict the future performance. And the other component, we compared the PPCs with some external measures. Specifically, we choose the PSIs from the PSI 90 composite, as well as the risk-adjusted mortality rate here as the external measures and the criteria. So let's talk about them one by one. We will start with a predictive validity. Yep. So as we mentioned, predictive validity means that the current results can predict the future performance. So this is important, and the idea is that, for instance, for the MHAC program, the idea is to use these quality measures as a vehicle to monitor or incentivize hospital improvement. So such PPC measures should have certain stability over time and not changing drastically from time to time. And with this in mind, one good metric to capture this one is to conduct the correlation analysis for these PPCs over time. And in this study, we use data since calendar year 2012 until the first 2 quarters of data in calendar year 2015. And we calculate the weighted correlation of hospital PPC rates between each of the consecutive calendar years for all PPCs. By doing so, we have 3 correlation analysis results for each of the PPCs. Namely, we have calendar year 12 versus calendar year 13. We have calendar year 13 versus calendar year 14, and 14 versus the first 2 quarters of 15. And we treat PPC measures as with predictive validity if at least one of these 3 pairs of correlations are shown to be positively correlated with statistical significance. So this is the current criteria we use for this analysis. So next slide, please. Here is the summary results. And as a result, we identify 15 PPCs with low stability in our study. If you look at what here we call inconsistent PPCs. And we could also notice for tier C has a higher proportion of unstable or inconsistent PPCs comparing with tier A and tier B. So for instance, for tier C, there are 31% of the PPCs are shown to be unstable over time. Before we move on, I just want to make a notice here that so many of these many of the unstable measures, PPC measures we identified here are also shown to be low in reliability. For instance, you may recall if we look at the tier A, the PPC 38 is also low in reliability, and also PPC 17 and 18 from tier B are both shown to have low reliability in our reliability testing. And also there are a couple of more in tier C as well. So I just want to make a note here. Yep.
So Faye, in this analysis, basically, is it fair to say the inconsistent PPCs are jumping up and down between the years, right? Yes. So they are not really correlated within the consecutive years.
Mm-hmm. Yes.
This is Tracy. Just one more question to make sure I understand what we're looking at and the analysis that you did. This is looking at all of the PPCs across the whole hospital field from one year to the next?
Yes. Yes.
So like like what you might be looking at is the rate of say PPC3 across in year 12 to 13 and 13 to 14. Is that what the kind of the measure is?
Yes.
Hospital-specific PPC rates, right? So he's looking at hospital PPC rates in 2 periods and see if they are correlated.
Okay, not the whole statewide.
Not the statewide.
Okay.
No, not statewide. No.
This will show my complete ignorance and naivete about this. But so if a hospital were actually improving and going down, would this analysis pick it up as invalid? No. Okay.
So
this is jumping around.
Right. So if all the hospitals are moving in the direction, then there's going to be a correlation between the 2. So this is showing that some hospitals are going up and some hospitals are going down, and overall you don't see any correlation between the base year and the measurement year. So one of the issues is, the coding improvements that we do, that probably impacts this. But at the end, what it's saying is the movement across the hospitals is not parallel when you look at the 2-year analysis.
Thank you.
Okay, yep. So then let's look at the next part. Next piece is about the convergent validity. And in the first part of the convergent validity study, we compared PPCs or a group of PPCs with patient safety indicators in the PSI 90 composite if they are measuring at a similar domain. So as you could see from this tables of instance, we have a PSI 3 and the PPC 31. They both measuring about, for instance, about the pressure usher, and also for each of the rows, so they're in line with the similar domain. And we also conducted the correlation analysis between the PSI and the PPCs. And as you can see from the last three columns, overall idea is that most of the PPC and the PSI pairs, they have pretty consistent patterns over time. And meaning here it shows in yellow, meaning that is with a positive correlation, and that correlation is also statistically significant. And I just want to make two comments here as shown as A and B. So for instance, we notice for the row that the label A corresponds to, which is the PSI 11 with 3 of the PPCs. We see those the correlations there are some gaps between the correlations from year to year. So one way to interpret that one is we notice, for instance, PPC 63 is shown to have a low reliability in our previous testings. So that sort of makes sense if the results could jump around from one year to another. Another one we look at about the row that label B corresponds to. We notice really the correlation between the PSI 14 and the PPC 38 are low consistently over time. One way to see this one is, as we notice, PPC 38 is with low reliability in our testing, as well as the values are quite unstable from time to time. So this may due to the reason that they are low when we do the correlation analysis between the corresponding PSI and the PPC, the correlation results could be low. Next slide, please. So I think we covered this one already. Yep.
Can I ask a quick question on the correlation before you go on? This
Sure.
is Justin from Mercy. I see the low correlations, and I think I understand that. But in like the example, the third one down, PSI 07 central line, where the correlations are 54 and 58%, but then it jumps up to 85, and I don't know if you can express it as a percent. But is there anything to be made of that pretty significant fluctuation in the calendar 14 period? Because a lot of the other ones kind of have a consistent, except for the ones that you've called out, they kind of have a consistent correlation. I know it's high and positively correlated, but it goes from 54 to 84. Is there anything to be made of that?
Sure. A simple answer, a quick answer is that we haven't checked specifically about the magnitude of the reliability of the correlations for this one. I think the reason, the rationale we put there is we identify, we know this, for instance, the PSI and the PPCs, they measure a similar domain, but their specifications could have some differences, such as their inclusion and exclusion rules. So we allow for some of the differences between the PSI as well as the PPC. And also, with that in mind, when we conduct the analysis, our main concentration is see, okay, if they have a high, if they have a positive correlation, is that statistically significant enough to claim they have a positive association from one to another? So our main concentration at that moment is focusing on this piece. But I think one way, if we would like to look at this one, maybe that would be helpful to drill down about the hospital level results and conduct some exploratory data analysis. I think that may be helpful to address such questions. Does that answer your question?
Yes, thanks. Sorry.
Okay. Yeah. I think we covered this one already. So next slide, please. Yep. So in the last part, we would like to conduct another piece of the convergent validity. So specifically, we would like to compare the PPCs. We would like to explore the PPCs with the risk-adjusted mortality rate. So using the hospital level all-payer risk-adjusted mortality rate, we identify there are 7 PPCs with a significant positive correlations with the mortality rate we have. And by the way, here the mortality rate data we use is a hospital level mortality rate. And we see, based on the results, we see some of them are also identified as main drivers of mortalities in different health research literature. So for instance, we see like shock is in here, and also epilepsy is included here. So this gives us some, I think this gives us some information that for these PPCs, they have quite a strong association with mortality, and this consistent with the research literature findings as well. So with that, I think this is the main information we would like to deliver, but I'm happy to answer any questions and hear any comments.
Thank you, Faye. I think this was really good. So we have varying degrees of understanding statistics, but in general, it seems like, is it correct to say, both reliability and validity, there is some common information you glance at. Certain PPCs are problematic both in the reliability test, also in the validity test, and then when you look at the mortality relationship, granted, you don't expect all the PPCs to be related to mortality, but you see that similar relationship there as well.
Yep.
So this is. I'm sorry. Can I just make one comment? I think it was helpful to do this. Thank you for doing that. My one question that I have in looking at this is, what kind of a correlation should we expect, and what kind of a reliability score is a good score? I mean, I can follow what you're saying on statistics, but I don't have a bearing of what's a good correlation. We're used to looking at R-squares, so I have a sense of when we feel like that's good, but I'm not used to looking at correlation.
Yes, to address about the correlation and R-square question, I think here what we adopt is we calculate the weighted Pearson correlations. So if we sort of, if we think in this way, if we visualize the data in this way, which each of the data point as a hospital PPC scores. Let's say let's consider the situation of the correlations between 2 consecutive time periods. In the x-axis, you have the PPC rate from one hospital, and the y-axis shows the rate for a different time period. So in that sense, if we do the linear regression, so I think in that sense, the R-square we get is consistent with the correlation analysis we put here using Pearson correlation. So a short answer is they are relevant if we put some model framework there.
So the range is again 0 to 1, and
yeah.
It's kind of in social science, 20% seems to be a good correlation. And so it depends on the field, but in general, around 40, 50% in everywhere considered to be a strong correlation. And then on top of it, they do the statistical analysis so that they look at the the variation around it. So the number is high and also it's statistically significant.
Yes.
So, Shule, I have a question. I don't want to get ahead of where the work group is, and I know that there's some other slides here that talks about the individual PPC measures and validity and reliability and what we're going to do about it. But if I look at page 5, when it talks about the reliability by hospital, and I'm focused mainly on the tier A and B, and obviously throughout this document, PPC 38 has some issues related to it. But if I go down to the PPC 17 and 18 with the major GI complications, it looks like there's a fairly significant number of observations, but yet pretty consistently hospitals have low reliability. So I guess my question is, taking the data and then kind of pivoting into, well, what do we do about it? Do we think that there's coding challenges or education, or is it just a bad measure? And do these PPCs see low reliability nationwide? Is this just a Maryland phenomenon? Like, what do I do with this data now that I know that it's not reliable?
So here we need to combine our clinical knowledge to understand what these numbers mean. Obviously, we don't have the national benchmark, so we're still working on the Maryland side. So looking at this, Diane is going to go through. We kind of said, oh, you see both, gastros here showing up. Is it about the defining significant bleeding or not? Is that the issue? So the next phase that we wanted to do is combine them and look at them together to see if it is a matter of defining the significant bleeding issue. In some cases, I think some of them are small numbers, so that could be the reason. So now it comes, so this was the science piece. Now we are in the art piece to kind of see how we can implement it and get a better PPC list.
And so again, the things we're considering are dropping them, some of the clinical clustering to see if that is relevant and would improve the reliability. And then beyond that, also obviously not having these in tier 1.
Yeah, I would request, you take this and talk to your clinical folks and see if they say, oh yeah, that makes sense. We know this is a big problem in the coding area. That will give us the contextual validity to these measures.
Right, so I will go ahead and go back to the HSCRC slides and slide number 5 that has some, mainly we stuck with the tier 1 PPC considerations because those have been the ones identified by the industry, by MHA, and then also the ones that we historically have had in tier A, and then we sort of are showing that up against the reliability and validity testing results, as well as the case numbers, so that we could get a sense of magnitude. And then Mathematica has weighed in on what they think might occur. Now, some of the Mathematica suggestions were just to remove or suspend, but we're also considering an alternative of combining clinically alike PPCs. So if we look at the table, first one that was in tier 1 for us in 17 is acute pulmonary edema and respiratory failure. It also has been identified by MHA and the industry and does not have issues with reliability and validity. So therefore, we want to keep that in tier 1. So I think as we look down the list, if we want to talk about individual ones, we can stop. But you can see this first cluster, if we go down to, and also these are all pretty high volume PPCs, going down to PPC 14. When we look at venous thrombosis, that is not on the MHA list. However, it has been historically on our list and has no validity and reliability issues. So mathematics.
The same is true for number 9 as well.
Right.
Of it was recommended on the MHA list to remove them, but given that there weren't reliability issues, we were keeping it in Tier 1.
Right. So, yeah, thanks, because that's a really skinny little row that I'm in with my glasses here. We now have in hospital trauma and fractures, and it has low stability. Remove it from the tier. So you can kind of read the table and read through which Ppc'S there are. The cubitus ulcers are a never event, and because they've been an issue of national significance, they do have low stability. The number's quite low in terms of case volume. There's a recommendation to remove it out of Tier 1, whereas previously we'd had a sort of rule that all the never events would stay in the top tier. And so on. So we, Ppc 38, the rogue Ppc, that one, there are other data sources that measure wound infection post-operatively, and surgical site infection is one area that the NHSN measures. And in fact, when in MHCC's efforts to do auditing, they took our data and bumped it up against what was being reported, and they found that our cases were finding 20% more of certain surgical site infections using the administrative data that were not reported at NHSN that should have been. So
I asked you to please qualify that statement. That should have been.
That met the criteria to be reported to NHSN.
But administrative data is not surveillance data. We can move on.
All I'm saying is they did case finding to do chart audits, and in the chart audit, using the cases from our data, they found some surgical site cases that should have probably been reported to NHSN. So, there are other data sources and more there than, in my view, than meets the eye, but there is a recommendation to remove it based on validity and reliability. And then if we go to the next page, there are no low reliability or stability issues. Some of them are on the MHA list, and these are all recommended to either move or keep in Tier 1 by Mathematica.
So when you say remove from Tier 1, where are you removing them to?
In some cases, we have to figure out if they should be paired with another measure to boost their reliability and stability, if that makes sense clinically. And in some cases, we may not use it for measurement for the program at all.
Right. So again, I think we're hoping to get some thoughts on how, on the idea of moving them to a lower tier or removing them, and then we can do some modeling of what that would look like.
Right. And then we did do a first stab at some clinical clustering, but it's not fully baked, so I'm not gonna. We didn't share it, but in every case it boosted the reliability and stability of the measure. But that makes sense since they were paired with high reliability measures. So, but the question is whether they were the right combinations. But so there was a first stab at trying to do that. But that would be the thing that we would ask if you all could weigh in based on vetting.
Yeah, I'm just
PPC
trying to understand,
list.
like, weigh in on what, and I think this gets to what Ed just asked, which is, like if you just use Ppc 38 that we just went through, low reliability, low validity, and it says remove from Tier 1, but are you moving it to Tier B or C or not at all, or combining it? I'm not sure how to.
So we want to get rid of 3 tiers. We want to do 2 tiers, right? So Tier 1 and Tier 2, because there's going to be a very small number in the middle. So that's one decision that we would like to get input. And the second one is just focus on Tier 1. I understand MHA went through several discussions clinically to pick the list. And then when we add the stability results, there is some mismatch there. So we kind of said, okay, if it is not reliable or stable, we don't want to put them in tier 1. So, but then there are some additional ones that are still there because it was there last year and it's still valid, but MHA list doesn't include. So that's a discussion we would like to have. See if still, why are, they were there, now we are removing, why are we removing them? There is no statistical basis for it. Then the question about what are we going to do for the rest, there are measures that are below that 0.4 threshold that the Mathematica has. They are completely look like random measures to us. So the decision there is remove them completely, or if we see that, oh, yeah, but that's an important PPC and we are paying attention to it, and it does make sense to combine that PPC with another clinically relevant one and keep it in the program. So that's the decision
that we're asking input on.
Right, that we need to think. And
I'm not trying to be difficult at all. I'm just trying to make sure that I can get the information back to my team so that they can provide the input. So I think if I had a list of what you're proposing, like PPC X, remove it completely, PPC Y, move it to tier 2.
Yep.
And that way I can get you the feedback that you're looking for.
We can revise the list. We have that. We wanted to be a more open, have this to be a more open conversation rather than having a foregone conclusion about what that should be. Since you're asking for it, I will give it.
Well, I don't want to speak for everybody else, but it's
a general table
to have an open conversation.
Like all 65 PPCs, information next to them, reliable, whatever, current tiering and proposed tiering or proposed decision.
We kind of have it, but it wasn't fully baked.
Okay.
But some of these are combined clinically already, so we may go back to the uncombined one and just offer that. And so combining is also an option.
This is Barbara. I also think you'll have to be very specific with us about how you want that feedback. Is it any hospital responds, or do you want MHA to act as a collaborator with the hospitals? But for instance, when I look at the PPCs that we're moving to tier 1, and for instance, again, it's the 2 OB that concern me, I start to wonder if there are still definitional issues that we need to discuss or other issues that we need to discuss that cause this to move up to tier 1.
Well, and just so you know, on that chart, that was because the MHA feedback was to move those all to tier 1 already.
Yeah.
So that was why we did that. If they had potential reliability issues, we may have done something different.
Yeah.
And that came out of the process of talking about definitions, including those OBs, knowing that there's still we're not sure on how many hospitals have adopted those kind of uniform definitions, and it does take a while. Just because somebody decides on a uniform definition doesn't mean that all the physicians agree to go by that definition in their documentation.
So like 37 and 38, I think, would be candidates if you consider combining them, because maybe that's why 38 has a problem, because it's so many few cases, and the only difference is that a follow-up procedure was done, and so maybe the two combined might not be as unreliable.
Yes, and you're right. They don't have issues when you do that, because that's one thing we ask for Mathematica to model.
You'll get a list.
Right. So when we get the sheet, it'll say 37, 38 combined.
Right.
And that's what we'll give feedback on.
Well, we can give you one with them separated and combined.
And what kind of time frame are we talking about? Because it does require physician expertise.
Well, this will rely,
I think probably prior to the next meeting, like probably several days before the next meeting, which is the 16th of December, would be ideal.
But if we're going to need modeling on these to make a decision for a final policy.
At the end of the month, that's possible.
So I think mid-December.
5th. I don't know what date that is.
Mid-December, we'll push the, I think mid-December is a reasonable time to expect the combination issues. I don't think modeling, we could do some modeling with the tier 1 and see what the impacts are. I think at the end of the day, it's not going to impact the actual results of the modeling, if you see what I mean. So these are adjustments on, if we get a feedback on the tier 1 and agree on it between now and the next meeting, then we could do the modeling based on that and do some assumptions on excluded Ppc's and combined Ppc's. And based on the input in the next December meeting, then we will finalize and do another modeling with those revisions. But I do expect that there shouldn't have too much of a difference between the two. Because we already did 3730. So we have some ideas for the combination. So what we are looking is fine-tuning those definitions, and it shouldn't have too much of an impact.
Shirley, just one comment generally about this idea of removing measures. I hope the bar for that is going to be pretty high. I just, some feedback that CareFirst has gotten, and I've gotten personally from folks that are in the hospitals and coding, is that I know resources are limited, but when you remove a measure, the progress that has been achieved by a hospital in that particular area, the threat is it just goes away. And so, hopefully we could keep that in mind, that dynamic. And hopefully the preference is to try to combine measures to make them more stable as opposed to eliminate them altogether.
I have another question about 65. So first, there's a very high number of UTIs without catheterization that are hospital acquired. And how do you prevent that? I mean, I understand catheter-related UTI is something that you prevent, but how do you sort of prevent a non-catheter related UTI that's acquired in the hospital? I was looking at it and I was sort of thinking about from a clinical standpoint that, how do you prevent something like that?
Don't look at us, we are not clinicians.
Clinicians are still trying to figure that out.
I mean, that's where, again, there is patient variation that impacts.
I mean, it's a very high number of cases. So.
I
You wonder whether the POA flag was properly applied.
I think that's the key there.
Maybe that's what it is.
Yeah.
If you're interested in looking at the clinical logic, we have access to that from the PPC manual, so that you can see what is driving that, because we would love for you to weigh in if you'd like about that.
I would wonder about the POA flag issue more than anything else.
Yeah, I think as we look at this and we're refining this and getting further, obviously some of these refinements are going to take more time than we have to make changes for next year. But I think we need to keep in mind the progress that's been made, and Diane, you mentioned it at the very beginning. Over the years, there's really significant progress made. So while nobody wants to hit the brakes on this project, we need to keep moving and improving the quality of the care and reducing the potentially and the key being potentially avoidable conditions. But I think at the same time, as we look at what we've done, I think we need to understand and maybe take our foot off the gas a little in terms of looking at either the revenue risk or the statewide targets, and maybe easing up a little while we get into this deeper issue of what are the now specific things. Because without a doubt, we've made significant improvement. I think all of our hospitals are better places for it, for what has happened over the last 4 or 5 years. But I think as we look forward, it gets more and more difficult to get down to the root cause of those issues, and getting, already there's an enormous amount of work by physicians, nurses, the quality staff to affect these things. But to really understand as we get finer and finer how we make that improvement and making real clinical improvement. I think, we're beyond the documentation and, the coding and all that thing. I think most hospitals have done that, gotten all that work done, and it's really about the clinical improvement, which is a much more difficult thing to do. And if we can ease off the gas a little as we make that progress or continue to make progress, I think it'll allow the hospitals to really focus on the clinical improvements going forward rather than
the things, again, historically that we've been able to make the biggest changes in.
Mm-hmm. Thank you. So I want to move to the readmission one. So we are hoping that the draft recommendation for MHAC will go up for the December commission meeting. So we keep the schedule. So the tiering, so we'll see. We do some modeling, and then if you feel comfortable, the difference between the existing and the modeled doesn't have too many differences, we may be comfortable putting the draft out, because that's something that we work technically. It's not part of the recommendation in the vote. So for the vote, what we have is the statewide target and revenue at risk. So I think those are the two. That is the policy questions that we need to we could put the draft and continue to the discussions in the December meeting, and the final vote is in January. So we don't want to delay that process too long, at least for the MHAC, and then I think there could be some delays for the readmission one.
Great. So we're going to move now to readmissions. And if I can get this, okay. So again, some of the considerations we have for 2018 are going to be some measure updates, and we'll talk about that in a minute. We'll talk about the issues of having it be improvement only versus improvement in attainment. We'll talk about a topic we had a lot last year, which was whether we should have an all-payer target or have a Medicare and non-Medicare target. And then we'll spend actually bulk of our time looking at the efforts we've had on incorporating a socio-demographic variable into our program, specifically looking at some of our analysis on the area deprivation index that was shared with our subgroup, but that we want to share with you today. And then, less so, but we will also have to think about targets and the payments adjustments. So the slides, for some reason, are funny. I thought I had it fixed.
It's okay, Allison. Yeah, we can look it up here.
Okay.
We don't have much time.
Okay, so this first slide just talks about readmission measure changes, and the biggest change that we're proposing is actually a revision of the transfer logic. So currently, all we do is count transfers if the date of admission is the exact same as the date of discharge. Date of discharge is the same as the date of admission. However, with our transfer policy, we have a slightly different definition, and there are different definitions being looked at by CMMI for our measure, and different definitions in the Yale hospital-wide readmission measure. So what we've done here is tried to adopt what that is, and I've just tried to show you the top 4 lines are saying, it's the same hospital, but then it depends on if it's a different or the same diagnosis with a subsequent admission, and it matters if it's the same or the next day. So if it's the same hospital and you have a different diagnosis or the same diagnosis, and the hospital, same hospital, different or same diagnosis, and it occurs in the next day, that would be counted as a readmission under our current logic and under the proposed logic. The differences come in when it's the same hospital and they come back on the same day, but it's a different diagnosis or different APR-DRG, then you're going to end up with that being now counted as a transfer. Counted as a readmission, whereas before it was a transfer. However, if you end up at a different hospital, doesn't matter, same or different diagnosis, on the next day, those will now be counted as transfers instead of readmissions. Sorry, I know.
Okay, so here's
I apologize.
So the current one is the same day, right? If it was same day, regardless of whether it's the same or different hospital, it's a transfer. So the new definitions are expanding it to the next day, so it could be same day or next day in terms of time period. But then looking at the readmission occurring to the same hospital, the logic is if the patient is coming back to the same hospital with the same diagnoses, then so it's the same hospital, same diagnoses. If it is the next day, then they think it's not a transfer. You can't transfer the patient to the same hospital with the same diagnosis. So that's kind of the logic there. If it is to the next hospital, no matter what the diagnosis is, it's a transfer. So if it is another hospital, they are saying, okay, maybe it crossed that 24-hour threshold, so we no longer want to do it same day, but we are doing it the next day too.
That does account for that problem for having
Yep.
7 p.m.
Right.
Yes. Yes.
Right.
Thank
So the only problem is for the same hospital, there is a difference, and there, for the next day ones, if it comes with the same diagnosis, it's a readmission, so it's not a transfer. Yeah.
Can I just ask a clarification on the third one? Sorry, this is Pat. The third one down, same hospitals, different diagnosis, same day. So we're talking about I discharge a patient, and then they come back that same day with a different diagnosis. Okay.
Yep.
I just wanted to clarify.
And that will be a readmission.
Okay.
Yeah, that was my psych rehab oncology distinct part unit.
Oh, so you're saying they actually are
They
discharging
could,
from the acute
yeah.
side to admit to the.
Right. So that
Right,
looking at the
Yeah.
3 and 4.
Right.
I mean, if you have the same diagnosis and you're coming back to the same hospital on the same day, how's that a transfer?
Yeah, we'll take a look at it. There is.
Those are the two that
Right.
I almost feel like they need to be reversed. Okay.
Yeah.
Okay. And then, so we will continue to look at that and make sure this is accurate, and try to summarize it in an easier way for people. The next thing is I just want to actually reference a memo that was sent out earlier this week regarding the impact of ICD-10 on some of our quality measures. And in that memo, we've provided the I-10 codes that will be used for the planned admission logic. And this is a mapping of I-10 back to I-9. And the codes we have, we obtained from CMMI so that we would be ensuring we're matching their planned admission logic. So next, as you can see on the slide, this is just our general progress to date. And I just want to remind everybody and show them that this is the monthly case mix adjusted readmission rate for all payer in red and Medicare in gray. And in the table, what it shows is that through January through August year to date, in 2015, on an all-payer basis, there's been about a 7.1% reduction in admissions and about a 6% reduction in Medicare. Again, our targets for hospitals overall was to not face penalties at the 9.3% improvement, and there are about 15 hospitals that are achieving that. We did provide also a table of the current results by hospital in case there are any questions, and what is added on to that is it's both the normal all-payer data that you would see, and then also the improvement in the Medicare rates by hospital are there as well. Okay, so next, one of the things that we're having to look at again is the issue of improvement in attainment. And at this point, I think we are still looking at keeping this program as an improvement program, but looking at the correlation of the 2013 case mix adjusted readmission rate and the calendar year 15 year-to-date change, we do see a couple of things. One, we do see that there is some correlation here, but what we see if you look at the hospital with the highest readmission rate of a little over 18%, you see that they've had significant improvement. And you see then, but however you see on the other side, you do see 1 point where, you know, the hospital had a very low readmission rate and they seem to be having an increase, which may point to that it is more difficult to improve. We are looking again at some sociodemographic adjustments that might take, help with some of these issues, but we may need to think again about that improvement versus attainment issue. If you take out those two extreme points, the correlation between improvement and attainment is not nearly as great. So next we have the issue of the all-payer versus the Medicare target. And what we show here is just the correlation between the change in the all-payer risk-adjusted or unadjusted readmission rate and the Medicare unadjusted readmission rate. And there's very high correlation here. And we've looked at other things where we've looked on a monthly basis at what is the percent change in the unadjusted readmission rate for Medicare versus the all-payer adjusted rate. And we see that more recently those are much more matching up, such that we are leaning towards advocating for still maintaining an all-payer target and not having a separate Medicare and non-Medicare target.
So some of you would remember for sure, it kind of damaged some of my brain cells permanently. The all-payer versus Medicare, if you remember last year, we had concerns about that the gap in the trends were opening up. With the new trend that we are seeing in the last 6 months, actually it's narrowing down, so the correlation is increased. So because of that, we don't, if you remember, we said we are going to look at it, and if we see that they are diverging, then we'll reconsider it. The trends are on the other side, so our concern is now less and less. So we think that to keep things simple, it is better to keep it on an all-payer basis, and we seem to be hitting our Medicare target with the CMS this year.
What is the percentage of Medicare patients you consider to be all-payer? What percentage of that would be?
Between 45 and 50%. Right,
half
majority of the
weighted anyway.
Right. Right, they are right. That was the discussion. It was dominating. I think what happened last year is because of the ACA and the new Medicaid patients coming in, all-payer denominator, expanded while the readmission rate wasn't catching up to it.
Okay, so next we're going to switch gears and talk about the area deprivation index. We have been working with our contractor, Dr. Amy Kind from the University of Wisconsin, and with others on updating the area deprivation index. The original, this is a validated consensus-based measure that is available at the block group level, and it was first created in 2003 based on the 2000 census, and it has been used widely in research and has been correlated with many other outcomes. What our contractor was able to do was actually update the measure based upon the American Community Survey. So in 2010, they no longer did the long form of the U.S. Census, and instead it is now done as part of the American Community Survey, and takes the place of the long form. It's a random sample of the U.S. population. It's annually updated, and at the block group level, it is the 5-year data is available at the block group level. So the most recently available data was the 2009 to 2014, and they used that to update the ADI. They used the exact same methodology, although they updated the factor scores. So they updated how much weight some of the individual items had on the survey. So let me switch really quickly. These are sort of the general components. It's a 17-item scale. Things that are measured are things like education, income, poverty, housing costs, housing quality, employment, and single-parent households. So under, some of the questions are actually related, for instance, to having a telephone in your home. Well, that's really not weighted it's weighted much less under this updated version. So everything was still included, but the weights in terms of what importance those factors had were updated. So next, and we're actually in the process of discussing. Sorry, can you get it to line up? That one. No, that one, Maryland map. So we're actually in the process of getting some of these maps updated because these are based upon the raw unindexed scores, which have now been indexed, but also we want to look at some more specific cut points within Maryland. What you'll see here is that the darkest areas are the areas with a higher deprivation. However, in previous work, they've looked at people with deprivation greater than 8 in the 85th percentile, and I'll tell you in this raw index score, that actually extends down into the middle color of that teal, kind of the middle color. So we're in the process of trying to update these maps so that we can just see that 85th percentile and above, and that would be specifically for Maryland and the range of scores within Maryland. However, I think if you go to the next slide with Baltimore City, I think at least comparing this to some of the things that we've been presented previously on some of the individual items that are represented on the in the census of education or income, you can see that similar areas are coming up in the darker colors in Baltimore City.
Yeah, I just want to know. Part of the advantage of index is we incorporate information from all these different ones. So even though it may be hard to interpret what it is, this will save us from the discussion, is it employment, is it poverty, is it something else? So this is kind of aggregating that and creating a geographic-based index. So, and it's been highly correlated with readmissions in the previous work, and we see the same thing here too.
Okay. And then the last map is just looking at the DC suburbs, and again, some of these middle teal colors, the darker colors might come out when we redo the maps to the 85th percentile more distinctly. Yep.
Question.
Oh, I'm sorry.
That's okay. And if you've covered this elsewhere, we could take it offline. Block
group level.
Block group level.
Yes.
My understanding that's even beyond the extra 4-digit.
So that is smaller than a census tract level.
Okay.
And I'm turning to my expert over here, Dr. James. I think he said there's about 1,500 people on average.
Maryland, 1,500. So my question then gets at, there's no way in any of the data sets that we have to be able to attribute patients into a block level. Is that correct?
So well, first of all, do you have zip code +4?
No, we took the address. I'm sure you have the address of the patient. So there is a program to take that address and give you the census block, and Chris did it for us.
Okay.
So once we do this, it is easy for us to put it back to the case mix data and share it with you in the readmission or MHAC report.
Okay.
Yeah.
Okay.
So just, I think this is a good place to put this in, since we got on the subject of ADI a little bit. The hospital field has had an introduction to the area deprivation index, and think that it's promising and interesting. I think there's also an interest in learning more about the ADI and having a deeper dive and being able to see some of their own data. And I was just wondering if that's possible to do within this time frame that we're looking for before we. I think we like the idea of using variables to address socioeconomic conditions, and then just the question is which ones, and if area deprivation index is one of the variables that we're considering, do we have enough time that we could have a little bit deeper dive on that? And I don't know if this work group is the place to do it or another special session or getting data to hospitals, I think that would be a big plus too.
I don't think we're going to, in the short time frame of meeting a January deadline, maybe be able to get data to the hospitals. We could do additional reporting on a hospital level that we could share at this work group or a different venue.
So what we are considering is, given the timelines, if we keep the existing improvement again this year, and then look at the attainment levels compared to some other, we could look at the Medicaid percent, that people are used to, ADI and other things, but keep the readmission reduction program kind of in a similar one, and then work with the ADI, and then for the shared savings adjustments that we do, try to incorporate the ADI, and that will give us more time to understand the measure and fully adjust the risk-adjusted readmission rates for the shared savings program. And that usually is around March that we kind of look at the percent reductions and also the measure. So that's kind of our way of thinking, rather than pushing everything farther. Readmission is still an important program for us. So yes, there seems to be a strong correlation between ADI and the readmission rate. There is no question. Although there is some question whether it's because of the Baltimore City driving and whether within Baltimore City you see that in relationship or not. But leaving that aside, literature says there is a correlation. But there is the improvement side is still not clear to us. Because some of the hospitals with highly deprived patients seem to be doing better. So I think if we focus on the improvement first between now and January, and then try to see, are we treating hospitals equally given their attainment levels, and then think about the impact of socioeconomic adjustment to the extent the data shows us, and then get that improvement program again, and then look at the attainments for the shared savings for March. That will give us 4 months to work on it. Alternatively, we could push everything and then try to combine and create a completely different program, but then that will require much more time for us to look at it. Yeah, I agree with you. We don't think there is any time for us and you to understand what the ADI shows.
Yeah, I get the timing issues. They're weighing on us this year, but that's what it is. I hear your point well about the time that it takes to do this. I guess really, if you look at the bottom line, where we come down to is it all depends on what that improvement target is. It depends when we look at the correlation between your starting rate and your improvement, that's a concern. And how do we fold all of this together so it makes something cohesive? To be honest, our biggest concern is we look at how the readmission rates have dropped statewide, how it appears that we're meeting our waiver test, and the big concern really becomes, can we structure these programs in such a way that it doesn't harm hospitals who are doing well and performing well, still recognizing that it's hard to define what a best performance is. But that's our bottom line concern is, I think so we've been on, the whole field has been on global budgets for coming up on 2 years now, so I think we're really starting to hit the stride on readmissions, and those incentives within the global budget are strong to reduce readmissions, and I think we're really starting to see that. So that's, for us it comes down to the detail.
Yeah, I mean, if you all focus on the improvement again between now and, if it will take us 1 more month, we are not wedded to the January timeline. If we kind of feel good about the improvement program first, I think if kind of trying to prioritize, if we are not at all comfortable with the improvement, that's a discussion we should take up in the December meeting. But if generally there is a general agreement on the improvement, we'd like to push the improvement, as quickly as possible with the concerns that you raised, and then take up the attainment one in a later time period. Dr. Saeed?
So is the idea that a risk-adjusted rate will take into account the ADI?
Yes. Well, again, I think there's a larger question there. How do you take that into account? You know, there is that bigger discussion about having different standards. So I think there is more to do there. One is looking at the impact, but also policy question is how do you take that into account? And, you know, there could be some additional revenues based on ADIs to take care of these patients, rather than trying to adjust the readmission rate, or you could do tiering. You know, there are things we could do with it. Yeah, you're right.
Sure. So internally, that would potentially work, but I think if you want to align it with the CMS measure, then it gets further apart in the risk adjustment.
This is probably not a question that you can answer, and I know you talked about you know, are we comfortable with improvement only, and we should discuss that more in December. I know what I can say is that there's a lot of consternation in the field now about hospitals that have low readmission rates and being asked to improve more, having that uniform target. I don't think we really have support for that right now. And so I think we need to know, you know, the amount of revenue that's at risk on, at least in this year, the amount of revenue at risk on that improvement is so much more than the amount of potential reward under the shared savings, that it doesn't balance out for a hospital that's got a low readmission rate. So I think that gets to like the heart of that concern, and that that's part of the balancing that would need to happen for us to be comfortable with like that kind of timing. And
yeah, I want to push back on the reward question. You have a global budget, so theoretically the reward is there, right, on the savings side. And I'm thinking about the CMS program that is only cutting. There is no positive adjustment there. Granted, it's not everybody. Maybe we will go to the top tier and do cuts there. So, you know, the notion that the performance program will give you a reward in a global budget, in a sense, you are getting the reward if you reduce it.
Yeah, I'm sorry, I should have been a little more clear. The concern isn't like to structure the policy to get a reward, but it's more that if I'm a hospital that has a low readmission rate and it's been low for a couple of years and I'm having a hard time meeting those uniform improvement targets, then I'm penalized under the readmission reduction improvement program, and then there's no balancing that out on the other program. So I'm just getting a cut, and I've already got a low readmission rate and have been addressing it for years. So that's more the balancing of why we're looking for.
I think the attainment rate would account for that, wouldn't it?
But there isn't one yet.
Oh, okay. So going forward, I see. You're talking about.
We're talking about a low number of hospitals, but the point is those are hospitals that are performing well. And as you mentioned, you know, it's really hard to sustain that level. Over time, you should, but there are some variations.
Right. The question is, yes, they have low readmission rate, but I haven't seen any data convincing me that they have a low readmission rate compared to another hospital, because some of those are in areas where there is no socioeconomic problem. So yes, you see a low, and then some of them are on the border, so I'm not sure what the actual readmission rate, so we need to think about the out-of-state issue. So yeah, if you give me a number and convince me, yes, this is a good readmission rate, I think we'll do it.
Apply the ADI and they'll all be high.
Well, and so I think the other thing is we want to think about having this program, and maybe we need to have some protections, but at the heart of the program, can we settle on the heart and know there's going to be these hospitals that may need to work with us to come in to, you know, present their own data. We can look at, you know, other data sources we have to assess the full extent of the problem, look at Medicare data to see out-of-state readmissions, things like that. But if we can try to work on the 80%, and then try to work on the 20%.
It sounds like we agree more than we disagree, but I just wanted to make one point of clarification, is that you said that the hospitals have the incentive in their global budget, which is true.
Tracy said.
On the,
we both say.
At least you repeated it, but you just said it. And that is true for the intra-hospital readmissions. You have to recognize that some hospitals have 50% or more of their readmissions happening at other facilities where when we reduce those readmissions, we have absolutely no financial reward under global budget. So again, getting to the attainment and the performance and the reward, I just want to make sure that that's pointed out.
Yes, Justin, thank you. Yeah, that's a good point.
Okay, so again, going to, I think one of the things is, yes, we'll be looking at how we might adapt shared savings and what role the ADI could play there, or what role the ADI could, or other measures could play even outside of the pay for performance programs. But going through this again, I just want to quickly, this is just the unadjusted readmission rate and the different ADI, technical term of ventiles, or the 5 percentile units. And as you can see, as you go up in deprivation, there's a strong correlation with higher readmission rates. And then the chart on the side is just giving you an idea of the number of discharges and the percent of total discharges in each of the ADI percentiles. So next, this is just looking at the observed to expected ratio. So trying to take the case mix into account. Do we still see a relationship? And while it's slightly less, we still do see a correlation with there being a higher observed to expected ratio at the higher deprivation percentiles. Next, we looked at it by payer, and sorry, I need to take mine out. And the blue line is the Medicare population. It's kind of hard to see if you're looking up at the slides. The gray line on the bottom is commercial, and the orange line is Medicaid. And the table on the side also just shows you what are the percentages of discharges in each of the ADI distributions. So I just want to point out, for instance, for the Medicaid population, close to 25%, or 30% are in the top 15%. So those points on the map are on the graph are going to be much more stable because there's a high number of discharges, versus in the lower levels of the ADI you see a lot of fluctuation, but there's much fewer discharges included. And that may be accounting for why you see sort of less of a relationship, which you would expect, between ADI and readmissions for the Medicaid population, since they're going to be highly correlated. Next, we looked at it by region. The blue is Baltimore City. The orange is actually PG County, and the other, the gray line is, again, kind of hard to see, is other areas. And then, again, I just wanted to highlight that in Baltimore City, in the top 15%, you have close to 45% of the people being in the highest deprivation area levels. And you don't see a high correlation in Baltimore City between the ADI and readmissions, but again, it's not taking into account that there's kind of there's much smaller numbers in the lower ADI levels. Next, we just looked at the correlation between the case mix adjusted readmission rate and the percentage of patients that were above the 85th percentile. And here we don't, we see a slight correlation, just as we've seen before, with if you have a higher percentage of patients that are in the top 85th percentile of disadvantage, you have a slightly higher readmission rate. However, if you go down to the next slide, we also looked at the correlation in the case mix adjusted rate and the and the change in the percent in the case mix adjusted readmission rate and the percent disadvantage. Next slide. Next one. And here there are two lines. The red line does show that there's this slightly higher correlation, although what it's showing is that these hospitals these sort of three hospitals that had the higher percentage of patients that were highly disadvantaged actually had a greater improvement in their readmission rate. If you take those out, you'll see there's less of a correlation between the change in readmission rate and the percent disadvantaged.
So the way, so is it correct? So the 60% of this is Bansa Cruz, I think. 60% of their patients are coming from highly deprived areas, and then you see that there is a 40% decline in their readmission rate. They are kind of our top. and you kind of see, and I think the next one is mid. So we are thinking about a linear relationship, but it might be about kind of the outliers. And if you are thinking about the improvement, maybe, as Allison said, it's about the 20% who are in the tails that we need to think about what to do, rather than trying to figure out the fully adjusted readmission risk-adjusted readmission rate.
Shule, at the risk of going backwards, can the by region, page 26, can you just tell me again how you've interpreted this graph, what we're supposed to take away from it?
So we are still trying to figure out the size impact. So let's focus on the blue one. And then I would ignore the big dip there. We think it's the cell size issue. But what it's showing is that the trend, if you just trend that blue line, is almost flat. So there is no relationship within Baltimore City, whether you live in Roland Park or you live in Cherry Hill. The readmission rate looks like it's not changing that much, as opposed to the statewide relationship. So we want to look at the Baltimore City a little bit more to understand what is happening there. So what we've been seeing at the earlier slides for the statewide might be just picking up the phenomenon in Baltimore City.
Baltimore City has the higher percentage of the total in that, ADI, so that would make sense.
Right, that makes sense. So if the question is whether ADI is impacting readmission rates, you should have seen the same upward trend even within Baltimore City, but you don't. So this is, you see what I mean? So in Baltimore City, you have areas with the affluent areas, right? So by looking at their readmission rate, we don't see that line between high and low deprived areas.
When you say line, you're talking about the trend line that's not actually on the graph of the blue line. So I guess the question would be, you take out the small cell size issue and then you draw a trend line, you would expect it to go up. And
you want to see that.
You're saying that you think it's flat.
It's flat. Yes. So we are looking at that a little bit. So that's the question.
But PG, you're saying is?
PG is also flat.
It's also flat, but PG we have a leakage for the readmission rates. So, for PG going to DC, the readmission rates, we are not picking up the true readmission rates in the PG as much because, some of them, about 30% are in DC. But for Baltimore City, the question what we are trying to understand, is it about the hospital or is it about the patient, right? So that's kind of the safety net hospital discussion. Is it about the patients they see, or is it about something about the hospital? So if it is about the patient, it should be unanimous that you should see that line going up in Baltimore City. You should see the same line going up in PG. But they are not as clear, so we are still trying to understand what actually is happening. So even if you just take one hospital, you should see a similar trend. A little bit different, but within hospital, if ADI is the true effect, within one hospital, if you graph this readmission rate, you should see an upward trend.
Okay, well, I don't want to spend too much time on it, but I think you have to be careful of scale and other things because, I mean, you've laid out PG, Baltimore, and other, and you're saying that there is an upward trend, but yet a lot of these are flat. So to me, it's a little bit in how you display the data, and I think we need to be a little bit careful on what conclusions we're drawing from this.
Yeah. I mean, these are just preliminary data. What we are saying is, okay, statewide we see it. We want to understand it at the local level. So in the payer one, we didn't mention too much, but the commercial, if you look at the commercial one, so that's kind of going into, well, even if they live in these highly deprived areas, if they have commercial insurance, look like maybe they are different people. Right. So, but then again, we still need to struggle that cell size issue, so we want to address it better. But just looking at the way we are looking at this data is what we wanted to share with you.
No, that's fine. That's great. And I just recommend using the same scale and other things when you're looking at the data.
It appears just, eyeballing the charts, as you just mentioned, that the payer seems to be a better discriminator compared to the ADI per se. because when you split it out by payer, and I guess my question on the Medicare is that pure Medicare, or is it the duals are also in there?
The duals would be in there.
The duals would be in there, so that would distort it a little bit depending upon what percentage of them are there, because they kind of track very similar to the pure Medicaid.
Right.
But they seem to at least break out a little bit differently than just looking at the ADI subsection alone and
right, maybe, maybe.
Maybe there's something with these Medicaid patients, like the psychological issues and those type of factors might be a much bigger discriminator added to the places where they live.
Right, so the only thing I glanced from the slide 25 was there's something about the commercial. I don't know about Medicare and Medicaid, but when we're looking at the ADI, eventually maybe it's the patients coming from these areas and not having a private insurance might be the...
Yeah, that's a good clarification, because I didn't take away from this chart. Since it's still an ADI chart, you can't say that the payer has more than the ADI. It's still an ADI-driven chart.
Yep.
And did I hear that at the local level, the hospitals understand the ADI? Okay, because I was looking at the list, and there are a number of Maryland hospitals now that have joined the readmission projects. And remember, these are projects that's working at the community level. So there has to be multiple hospitals in the project for them to be able to participate. So it would be great if, when we can get to the hospital understanding how the ADI may or may not be impacting their readmissions rate, because they truly are now, the ones that are participating are trying to dig as deep into the data as they possibly can.
So I kind of, first we need more technical evaluation and understanding this relationship, and we have the subgroup. And once we understand at the technical level, and then I think we need to translate quickly to the front lines to see, how to use this information. It seems powerful. It's so complicated. So we kind of need to peel the onion a little bit more before we start talking to folks who would be just using it for the interventional purposes. They wouldn't care about our statistics at the end of the day. So that's kind of, I think we have some more work to do, but I think we are fully committed to share that information as quickly as possible.
Okay, so this next slide, and again, I apologize, it's a little hard to see, is we actually have taken the latest data we have from CMMI to model how the nation in Maryland is going, because this is similar to what we did last year for being able to then come up with what is the unadjusted Medicare fee-for-service target we have, and then we had subsequent calculations to adjust that to be a all-payer risk-adjusted target. But what, and Shuli, maybe you can walk through this more clearly. So.
It's late, so we'll try to be quick. So this is kind of a similar methodology. So I would first focus on calendar year 2013, right? That's our base year. And we were 8% higher than the nation when we started. So that's kind of the revised number. And then in 14, when we did this last year, we had 6 months of data, and that's what we assumed. So the most recent data that we got from them, that the national readmission rate declined by 0.73%, C to L4. Everyone with me? And when we look at our trend, we actually declined by 0.5%. I'm just looking at last year. This is our revised numbers. We reduced our, by 2 percentage points, so we are at 6.7%. So that's the 14 numbers. Then we got the 2015 year to date, so this is June, first 6 months of data. the national number seems to be picking up, so they are improving by 0.8%. But our progress is great here. We improved it by 3.7%. So we reduced our difference with the national number by 2 percentage points again. So we are at 4.6%. So in the next rows, what we did is we just assumed, okay, the 6-month trend, if it continues, what will be our estimates are and what will be our estimates for the difference. So if you just purely take that number, multiply by the calendar year 14, we are projecting our difference at 3.69%, right? So then what we did is we calculate the target. So this is a revised target since we have new information. So our target for the Medicare readmission reduction is at 2.4%. So that's C4. So we are, if the 6-month trend continues, we're on our way to meet our target, and we have some cushion there, even if things change. So with that, then we did the similar, and then here you see in calendar year 2016 target. So this is the number that we need to work on. Is we assumed, okay, national number is going by 0.8. So then the Maryland, for us to close the gap by the end of 2018, our target is, Medicare target is at 1.18%. So that's kind of the math that we did. And this is just looking at the Medicare one. In the bottom, what we are concerned is our estimates. This is exactly the same thing we did last year, but if you remember, our numbers were quite different. So in the bottom, you see the estimated versus actual. So last year, around this time, the number that we were looking at in the national was at 0.35%. The actual came at 0.73%. So part of the reason why we are doing so good is we overshot the national number and undershot ours. So you could kind of compare the differences between what we estimated, what the actual came, to understand, you know, our up year-to-date progress. So on the improvement side for the Maryland, we had 0.8 reduction. You know, we overshot our estimate too, so we didn't improve as much as we predicted. And on the then for the 15, if you remember, we took average of the last 2 years, 3 years to be conservative. So we estimated that to be 1.3%. The actual came around negative 0.8. And then the required estimate in our model was at 3.9%. The new one is at 2.4%. So we purposefully overshot a little bit, but at the same time, what we are glancing from this is we need to do a better job between you on our predictions. So what we've been doing is we are not doing predictions really, we are just taking year to date and applying it. So Mathematica is working with us to kind of see if they could do a projection given the trends, and you know, hopefully by next meeting we may have a better methodology. But at the end of the day, I think we need to be cautious of the differences and try to come up with a reasonable target for us for the next year.
So can I just clarify and say this a little different way and see if you agree? Last year at this time, you were really concerned about the Maryland performance because of our projection of the national, but the national didn't come anywhere near the projection. This year we're doing quite well, and you're concerned because we still don't know the national projection. But we're in a much better spot this year than we were last year, and we're still trying to figure out the target going forward based on the national.
Yes, and I do think that the target is going to be smaller this year compared to last year. So it's just a matter of figuring out how much and what sensitivity we have around the number. I'm hoping. I'm hopeful.
This is a question that makes this projection, adds one more layer of complexity, is the other thing that we did was we started from here and then had to say, how does that translate to an all-payer risk-adjusted rate? So I know we're trying to look at those relationships too, I imagine.
Yep.
Is that coming, you think, hopefully next
Yes,
week?
for next time we'll have those more detail and try to come up with something. And there too, I think it's a good news because the relationship, we were concerned it was coming up, so we had much more add-on to the all-payer because we thought Medicare wasn't moving faster. So I think that's also closing. So I think that those are all positive things for the projections from our perspective.
Just the other suggestion would be, because the next meeting is fairly soon, if you do need to work with us in the meantime, either through Tracy, who would certainly be able to put together a small subgroup to do anything that you might need from us that would help us come to conclusions faster, I think would be a good thing.
Yeah, we'll work with Tracy on the timelines. I think that's a great idea, Barbara. Yeah.
So I think one of the key things in this context really is the assumption you put in for the national reduction going forward.
Yep.
Because if you look at the numbers just in these years, so in 2012 it was minus 3.1%. Obviously they're starting at a high base, so you expect a higher number than minus 2.34. And so I think one of the things to throw into the mix of your analysis might be to see what are the best achieving rates in some of the states and give yourself a little bit of that factor in so that you're aiming for something that potentially could be different from the flat 0.3% reduction going forward.
So earlier on, 3-4 years ago, we did get from the National Coordinating Center a state ranking, and Maryland was where, and it was by a slightly different measure, but Maryland was exactly where we thought Maryland was on that, and that was not something we made public, but we had it as sort of a reference. So I'm going to put Selma on the spot here and see if there's something by way of producing a statewide ranking list for readmission rates so that we can see where Maryland is relative to, it was really hard to find, but we finally, I got it eventually, and so that would be actually quite helpful, I think.
Yeah, we can certainly, now the National Coordinating Center has asked that we not ask for additional information that would cause them to have to do something until after the beginning of the year.
Right.
This might be something that
they already
exists
have
that
exactly.
we can ask for.
Exactly. Yep.
All right, so just bear with me a few more minutes. The last slide is the aggregate at risk. Any other questions on the readmission? No. Okay. So the aggregate at risk, and we already discussed this a little bit. So this is the updated amounts comparing Maryland to the national numbers. And as you know, we need to be at their level or higher. And then there are two ways of measuring this. One is the potential at risk, what we put on our maximums, and the other one is the realized risk. So they are measuring actually what we implemented. So these are showing the potential at risk numbers, and by next meeting we are hoping to put the actuals more to the analysis. But here, so for this 2018, we kept the amounts the same. So you see the, and the shared savings is plugged in number. It's not a proposed, just getting it from the last year. Obviously, we will be discussing that with the update factor discussions. And the PAU is also last year's number, put it in. So with that, you see that our total is at 8.6%, and the Medicare National is at 6%. So I mean, they are not changing theirs, and we are not changing ours, and you see the difference between us is 2.6%. I know the base revenue issues and all other things, but so this is the information, and our plan is to keep them the same for this year for all the programs.
Can you talk about the cumulative Maryland-U.S. difference I'm surprised that 2018
you know
doesn't change.
Yeah, I think that's a mistake.
Okay, so that should be
Yeah.
2.64 plus 2.64.
Yes.
Yes.
And our does CMMI have one more test on this aggregate
Yes.
risk?
Yes, so the actual implementation of the program. So in the Medicare, it's close to their actual because the way they do it is a relative adjustments, right? So they all go into it, whereas in ours, it's not, it's fixed amount. So, you know, we fix the point, so the lowest point in the base year gets the 3% penalty on MHAC. As they improve, we don't put that 3% penalty to any hospital. So to gauge that impact, they are looking at both the potential but also the realized, what we implemented.
And is that, so if we're supposed to be equal to or above the nation on amounts at risk, is that amount that's shifting, sorry, shifting among hospitals the reason why the number will now be like 5.18, 5.28, 5.28. So we're 5. So we're, if we look at the 8.64% compared to the 6%, we're above the nation by 2.64. Mm-hmm. And then if we look at our cumulative, we'll be at 5.28. Mm-hmm. So we're 5.28 above the nation on that one.
Right.
We don't know yet where we'll come out on the third test, but I'm just wondering, I'm looking for the reason why we're above on both of those when this is such an issue.
No, this is not, so we have two tests. One is cumulative number that we are looking. We are above, we have no issue there.
Uh-huh.
The other one is the realized one, and they are much closer to the national ones.
So yeah, so then you're answering my question. So the reason why this number has to be 5.28 is because when we start shifting the realized.
Yeah. 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 Yeah, you're right. If you lower this number, our realized is going to be much lower, and we may trip the wire there. We'll have more for the next meeting, or so, even before the meeting.
And I just have to say it. I know you've heard this before, and it won't be about the percentages, but it's about the if we're hitting our targets and we're performing well, the idea that we need to shift a certain amount of revenue among hospitals is hard to make sense of.
Well, you're right. The idea there is value-based purchasing. How much? What is the value? Global budgets, you know, we say we no longer value volume, and the question is, what do we value? Yeah.
Well, I think that's true. I guess just if we're meeting our financial targets and we're meeting our quality targets, so that's the value. And that is there a reason to? What further benefit do we get, and at what point do we start shifting revenue just to shift revenue rather than to do something meaningful?
Yeah, I don't think it's about shifting the revenue. It's about adjusting the rates based on quality and outcomes. And it's yes, statewide we are hitting it, but just because we are hitting at the stage, so should all the hospitals get the same increases year over year, no matter what they do on the quality? I mean, that to me, yes, we are bound by the contract on this one, but I think the issue is larger question that we all need to think about.
Yeah, I agree with you on that, and I'm not saying we shouldn't, you know, we can just stop paying and take away the quality-based programs. Where my question comes in is, let's say that all hospitals were performing better than the national readmission rate, for example, mm-hmm. Or within a few percentage points of the national readmission rate. So we're performing well. Would there still be a need to move revenue around based on readmission? If all hospitals are performing well,
if they all performing the same well, no. But there is a variation, and I do think that there is a value to keep pushing and having that incentive to do better. And I think it would be nice if you move to the national benchmarks if you can. I think that may be a good. Yeah. Beyond
the national benchmark.
Yes, not national average.
Top of the average.
Right. Not the national average. Some other national number we could move. Yeah.
Right. I think on the national side, obviously the hacks and readmits have a different sort of implication where you're just able to recoup, whereas on the value-based purchasing, you actually potentially could get even more, you know, in terms of the upside.
Mm-hmm.
And of course, it doesn't show here, but there's another 2% that's tied to the meaningful use program. So the total at play is -8% potentially for hospitals on the CMS side.
Mm-hmm. Okay. Thank you all. I'm sorry to cut the discussion short. I feel like I pushed it, but we'll pick it up again. So this is initial discussion on the aggregate. Thank you all.